Okay, so again, welcome and thank you for joining us for our first talk in our Black History Month Anti-Racism Speaker Series. I am Chloe Green, the overall chair of Black at APT, excuse me, which is APT's employee networking group for Black employees and the group charged with coordinating all of APT's Black History Month activities. So glad that everyone is here. We are definitely in for a treat today. As a reminder, this talk will be recorded and shared with all registrants. Want to give a quick shout out to the Black History Month Planning Committee, who has worked tirelessly to pull all of our events together. Also want to thank APT's leadership, particularly Black at APT's sponsor and our COO, Lisa Simeon, who has supported Black at APT and helped to make this speaker series possible. I don't want to take up too much time, so we'll move into introducing our phenomenal speaker, Dr. Jones. Dr. Jones is a senior fellow at the Satcher Health Leadership Institute and the Cardiovascular Research Institute at the Morehouse School of Medicine. She is a past president of the American Public Health Association and recently completed tenure as the 2019-2020 Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study at Harvard University. She is a family physician and epidemiologist whose work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. She seeks to broaden the national health debate to include not only universal access to high-quality health care, but also attention to the social determinants of health and the social determinants of equity. As a social epidemiologist, her work on race-associated differences in health outcomes goes beyond simply documenting those differences to vigorously investigating the structural causes of the differences. As a teacher, her allegories on race and racism illuminate topics that are otherwise difficult for people to understand or discuss. She aims through her work to catalyze a national conversation on racism that will mobilize and engage all Americans in a national campaign against racism. She was an assistant professor at the Harvard School of Public Health before transitioning to the Center for Disease Control and Prevention, where she served as a medical officer and research director on social determinants of health and equity. She has been elected to serve on many professional boards, including her current service on the board of directors of the DeKalb County in Georgia, their Board of Health, and the National Board of Public Health Examiners, as well as past service on the executive board of the American Public Health Association, the board of directors of the American College of Epidemiology, and the board of directors of the National Black Women's Health Project. She is also actively sought as a contributor to national efforts to eliminate health disparities and achieve health equity, including her current role as a faculty member of the Accreditation Council for Graduate Medical Education's Pursuing Excellence in the Clinical Learning Environment Collaborative, addressing healthcare disparities, and her formal role as a project advisor and on-screen expert for the groundbreaking film series, Unnatural Causes, Is Inequality Making Us Sick? So in other words, she's a powerhouse and she's amazing. So without further ado, I will pass it over to Dr. Jones.
Thank you so much. Thank you, Chloe. And I'm really delighted to be here at virtually and sharing some of my insights. So I have entitled, our remarks today, if racism is a public health crisis, then what does that mean for my work? And as Chloe said, when I was president of the American Public Health Association, which was in 2016, I actually launched our association and as many other communities and organizations and like anybody who would join us in a national campaign against racism that had 3 tasks. The first, to name racism. That's essential because if you don't say the word racism in our national context of widespread racism denial, you're complicit with that denial. So naming racism is essential. It's necessary but insufficient. We need to then move to action. So the second of the 3 tasks was and is to ask the question, how is racism operating here? To identify levers for intervention, targets for action. And then once you've identified those levers, to organize and strategize to act. So out of that year-long effort, all of my columns in the nation's health our monthly newspaper had to do with some aspect of racism. When I visited the state public health associations doing keynote addresses, I was like intent. And out of that work, I would say I take some small pride in the fact that now there are at least 176 jurisdictions, so cities or counties, or in some instances, 5 states, that have made formal declarations. Racism is a public health crisis. I'm not saying that all of them knew about Kamara Jones or APHA or anything, but I do know that the first one, Milwaukee County in Wisconsin, adopted the Wisconsin Public Health Association's declaration, which was directly tied to this effort. So it's amazing. And you can see, look here, the names that are in all caps, those declarations have been made at a state level. But you see, California has 27 jurisdictions, cities or counties. Ohio, 24. It's amazing. So now that's the if. If racism is a public health crisis, well, at least these 176 jurisdictions plus organizations and all have said, yes, we are now recognizing racism as a public health crisis in the light of the disproportionate impact of COVID-19 on communities of color, in the horrific light of the well-documented horrific death of Mr. George Floyd on Memorial Day last year. Yes, we are there. So now the question arises, what does that mean for my work? That's why you have me here. So here's our roadmap. And the signpost, there's a 3-part roadmap. After each section, we're going to open it up for just a little bit of Q&A. Then I'll go back to the second section. Then we'll close that, a little Q&A, and go to the third section. And the signpost in the roadmap are some of my allegories or, framing illustrations. So framing the work. What does racism have to do with the work that we are doing at APT Associates? And I'm there going to refer to my cliff analogy. Then we'll take a break. We'll discuss that. Then we'll come back. The second part is naming racism. And I'm going to bookend that with an allegory I call Dual Reality, a restaurant saga, share some definitions and framings. And then the other bookend on that is going to be my Gardener's Tale allegory. Then we'll have a quick break for Q&A. And then the third part of our journey is moving to action, where I will bookend that again with 2 allegories. The newest one, no, you haven't heard, because this is just the second time that I'm going to be telling it in this way. And the first time was last week when I taped it, but it hasn't even been aired. So cement dust in our lungs. So this one might be a little rocky. You'll have to I'm still feeling my way in telling this story. And then end that with life on a conveyor belt, moving to action. And in between all of that, I will include definitions, frameworks, things that you can operationalize. And if we have time, so then at the end of that, I of course want to invite your questions, but I also have a new thing that I haven't shown before, which is a primer, kind of a review of all of the frameworks and all the definitions and things. So maybe at the end, I'll feel like, well, let me show you the primer first and then open it up for your final questions. So that's our roadmap. Here we are, part 1, framing the work. And I am a family physician. I am a PhD epidemiologist. So even though your work at APT has to do with health and housing and the environment and immigration, and like you touch a lot of different things, I am going to share this cliff analogy, this cartoon animation, from the point of view of somebody in health, recognizing that all of you can make the leap to whatever your focus of work is. So if we're trying to understand different levels of health intervention, let's go. Whoops, boom. Somebody just fell off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we were concerned about other people who might come along that cliff face, so if we were concerned about community health, population health, public health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody's going to say, I know, let's put a net halfway down. That way, even if somebody falls, we can catch them before they get crunched up at the bottom. So that's a great idea. Although the more you think about it, nets do have holes in them. So some people might fall through the cracks. We could even make that a trampoline halfway down the cliff. No holes in a trampoline. But even if there were a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to be thinking about a fence at the edge of the cliff to keep people from falling in the first place. But even that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, we could move the population away from the edge of the cliff. I'm seeing some things. Is there something that I need to do in my presentation? Chloe, can you just let me know? Are you guys hearing me, seeing me all right?
Yes, Dr. Jones, but someone asked if you could go a little bit slower for some folks too. They just want to capture all the greatness.
Okay, I will try, but so I will try to go a little slower. Part of the pressure in my speed, and I really appreciate that, is that there's so much I want to share with you. But if we don't get through all of it, so be it. Okay. So what I've already said is if somebody falls off the edge of the cliff, we want an ambulance there to speed us on to care. But if we're concerned about others, maybe we need to put a net or even trampoline halfway down. But even then, with a trampoline, people still might be bouncing functionality, not able to get back to the top of the cliff. So we need a fence to keep people from falling in the first place. But even that fence could be insufficient if there's a lot of population pressure against it. So we also need to think about moving the population away from the edge of the cliff. So we're going to stop there with the image that I have so far and label these interventions that I have already described, where the ambulance at the bottom of the cliff represents acute medical care or acute educational interventions or acute housing interventions, homeless shelter and the like, acute care, as well as tertiary prevention. So in the public health side of things, we talk about 3 levels of prevention: primary, secondary, tertiary, where on the health side of things, tertiary prevention is preventing complications from disease that's already manifest. So that's your ambulance. The net or trampoline halfway down, these are our safety net programs, often in social services, as well as secondary prevention, which is early detection, screening programs. The fence represents primary prevention, keeping bad things from happening in the first place. And of course, in the health side, that includes vaccines. We're all on that right now. But it also includes policies like a tobacco 21 policy to make it more difficult for young people to have easy access to tobacco products. So, but that fence is still operating, even if it's a policy at the individual level. Moving the population away from the edge of the cliff, this is about addressing the social determinants of health, those determinants of health and illness that are outside of the individual. So they're beyond our individual genes. They're beyond our individual behaviors. They are, in fact, the context of our lives. And I know that you guys are all on this, right? Like you said, we got social determinants of health. But for example, they include individual context, like individual education, occupation, income, wealth. So clearly addressing poverty is an important way of moving the population away from the edge of the cliff. They include neighborhood context. So the quality of housing in a place, and that has a lot to do with the transmission of COVID-19 right now, or environmental hazards, or whether or not you live in a food desert, or what other people term, a fast food swamp. So addressing adverse neighborhood conditions, again, is another way of moving the population away from the edge of the cliff. So this is a nice cliff. We could actually, not only for our own understanding, think about the kinds of interventions that could be made in our sectors, but we could also have a conversation with communities and say, for example, how should we be spending our health resources? How much in ambulances versus nets versus fences versus moving the population, right? But as useful as this diagram is, as I have presented it so far, it has a huge fatal flaw. And the huge fatal flaw, as it is that it doesn't yet equip us to talk about how health disparities arise. So I want you to keep this image in the back of your mind, but we're going to shift gears for just a moment to talk about how health disparities arise, or any disparities, on 3 levels. And in the health space, and especially with regard to racial ethnic health disparities, we unfortunately have lots of evidence about differences in the quality of care received within the healthcare system. So the Institute of Medicine in 2002 released its Unequal Treatment Report, which pulled together hundreds of studies documenting the fact that, even within the same healthcare system, so even everybody in the VA system, even everybody covered by Medicare or Medicaid, there were very well documented differences in how vigorously your chest pain might be investigated or treated depending on your race, or how much pain medication you might get if you walk into an emergency department with a long bone fracture, depending on your ethnicity or your race. So we got that if we were to do the same study now, it would be thousands of studies documenting these differences. But even that Institute of Medicine panel recognized it is not just about what happens within the system, because we recognize not even everybody has access to the system, right? That's a second level at which health disparities arise. Differences in quality, differences in access to healthcare, curative and preventive, or differences in access to educational resources or housing resources and the like. But I'm hoping that all of us recognize that health is not created within the health sector. So a third level at which health disparities arise are differences in the conditions of our lives, differences in our life opportunities, exposures, and stresses, which are making some individuals and communities sicker than others in the first place. And when we actually want to contextualize these three levels at which health disparities arise, differences in quality of care, access to care, and underlying exposures and opportunities, we could actually draw that as a pyramid if you want, or even better, understand it as an iceberg, where the huge hidden base are the differences in the conditions of our lives. And then very often the same ones who've been made sicker are frustrated because of limited access to the healthcare system. And then even the lucky ones who get into the system are sometimes further injured because of differences in quality of care. So now, recognizing these three levels at which health disparities or educational, all of these disparities arise, we are now going back to the cliff. But now we're going to recognize that we're really not dealing with a flat two-dimensional cliff, but actually we are dealing with a three-dimensional cliff. And at some parts of the cliff, there might be an ambulance here, but maybe that ambulance has a flat tire, so it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, and maybe there's no net, nor fence, and usually at those parts of the cliff, the population is being pushed closer to the edge. So now let me label these observations about this three-dimensional cliff with how health disparities arise, where the differences in quality of care are represented when the ambulance is there, but it's slow or goes off in the wrong direction because it has a flat tire. The differences in access to care are no ambulance, no net, no fence. And differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, there's a whole new set of questions that arise. First of all, how did the cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along this cliff face? And why are different populations found at different parts of the cliff? And when we start asking and addressing these kinds of questions, we are now doing something that I describe as addressing the social determinants of equity or inequity, which differ from the social determinants of health. Remember, we described addressing the social determinants of health as moving the population away from the edge of the cliff, addressing poverty and adverse neighborhood conditions and the like. But when you start talking about systems of power that can differentially distribute resources and populations, now you're talking about social determinants of equity, including racism, sexism, heterosexism, economic systems like capitalism and the like. So with this cliff analogy, I've actually distilled three different dimensions of health intervention or whatever sector intervention you are concerned about. Where, you go back to your junior high or high school geometry, one dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along the line at the edge of the cliff is where we can display all of our curative and preventive health services right there, the ambulance, net, and fence. When we even on the health side of things talk about health, people will complete that thought to us and get immediately to health care or health services. And even universal access to high quality health care is still an edge of the cliff conversation And we need to get to universal access to high quality healthcare. Indeed, we do. We need to join the rest of the world in that way. And it's important because that is how a civilized society values all of its people equally. But even when we get there, that system in and of itself will not necessarily result in large and sustained improvements in health outcomes or the elimination of health disparities, because as an edge of the cliff thing, you can overwhelm any system if everybody's pushed up against the edge. So we must move into that second dimension, which I describe as addressing the social determinants of health. You know, we can put that in our flat, thing, moving the population away from the edge of the cliff. That is how we're going to get to large and sustained improvements in health outcomes, addressing poverty, adverse neighborhood conditions, and the like. But the trick there is that if we are about moving the population away from the edge of the cliff without recognizing that we're really dealing with a three-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must acknowledge and address the three-dimensionality of the cliff. We need to be addressing these social determinants of equity or inequity, including racism, sexism, heterosexism, and the like, if we want to achieve social justice and eliminate health disparities. So this is positioning attention to racism in the context of all of it. Addressing social determinants of health is like addressing the context of people's lives, but when you're addressing so that's, is there a bike path, right? Are there grocery stores in the neighborhood? Addressing the social determinants of equity is who is at the table deciding what community gets what, right? And whether a bike path is what we need. It's all about systems of power. And I'm going to talk much more about that later. Before opening it up for our discussions as a group, I want to just share with you 3 questions that have been raised so many times before that now I always share them. The first is for Dr. Jones. If this is a good way of us understanding different levels of health intervention or whatever sector you're in, and if we recognize that an ounce of prevention is worth a pound of cure, why are we as a nation spending so much money on ambulances at the bottom of the cliff? And I actually have generated over the years 6 different answers, but I'm going to tell you the first and the last. The most, what I say, cynical answer would be there's a lot of money being made on ambulances at the bottom of the cliff by healthcare systems, healthcare providers, pharmaceutical companies, medical device companies, and the like. But the core answer is that we are so narrowly focused on the individual in this nation that we don't even recognize that there's been a health problem until somebody has fallen off the edge of the cliff and either it's caught in our nets or we have to scrape them off the bottom and speed them on to care. So this narrow focus on the individual makes us not even understand that the closer proximity of that greenie population to the edge is a health problem. We are not even using aggregate measures of health like social cohesion or income inequality as health measures. We're just busy at the individual level documenting differences in adverse outcomes. Here's another question. Why are the greenies launching themselves over the edge of the cliff? And people ask this question when they say, well, why do those people eat so much fried chicken? Or why don't they read to their kids? Or why are they doing this? Or why aren't they doing that? Which also reflects our narrow focus on the individual, because when we're narrowly focused on the individual, it makes systems and structures either invisible or seemingly irrelevant. But it also reflects a second of what now I've identified 7 barriers to achieving health equity, more on that later. But the second of these is that we as a nation are ahistorical. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. So when we see the greenies at the edge, we don't ask what has pushed them there, what is keeping them there. We don't ask what skates were the oranges given to get away from the edge of the cliff. We're all about, oh, here it is, must have always been this way. Here's the third question. Most of us don't articulate out loud, but many of us act it every day, especially when many of us, we're not working from home, but we're working in another place, and we might leave our comfortable homes, drive through a distressed, disinvested community, arrive at our lovely workplace, and not feel a strong sense of urgency to do something about the distressed, disinvested community that we just drove through and the conditions in that community, right? This question, the situation looks fine to me, what's the problem with a 3-dimensional cliff, actually reflects a third of these barriers to achieving health equity, which is our endorsement of the myth of meritocracy. The story that goes something like this: well, if you work hard, you will make it. If you worked hard a little more, greenies, then you wouldn't be so close to the edge of the cliff. And this, I call it the myth of meritocracy, because yes, most people who have made it have worked hard, but not everybody who's made it has worked hard. We have prominent examples of that, but most people have. But even at the same time, there are many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and is being perpetuated by these systems of, these social determinants of equity, systems of structured equity, structured inequity, all of these things, racism, sexism, and the like. And to the extent that we deny the existence of those systems, we are endorsing the myth of meritocracy. We are blaming the greenies for where they are, not understanding that, first of all, there's systems pushing them and holding them to the edge, that every step that they try to take back is harder, and it might even be more slippery. And indeed, the part of the cliff where they have been pushed might even be higher, and anytime they fall, the consequences might be more dire. But anyway, at this point, I would like to stop sharing briefly and entertain, I would say, up to 3 questions, but at least one. So I'm going to sit here and wait for at least one question and look forward.
One question that's coming up a lot is, will people receive the slides after the presentation?
Yes, I will send the slides. And so I don't know how you guys will get it. And I have to say, I have like animations in the slides and stuff like that. So it'll be fun for you guys to play with them. Yeah.
Another question is, are you available for private speaking engagements?
You guys are so funny. Yes. Yes. A content question?
Kind of. I got one right here. One is, can you please break down all 7 of your barriers to healthy equity?
I will, and that's going to be in the 3rd section of our talk. So I will. Okay. If you guys are good, if you just like skimming, because I don't have a lot of time, which is why I started out talking so fast, I'm going to start sharing again. Okay. But if you have questions, we'll have 2 more opportunities.
Dr. Jones, there's one more question that I think is relevant for this piece. Someone said they're currently reading Caste by Isabel Wilkerson. Do you think the Caste paradigm is useful for examining the social determinants of health in the United States, and how U.S. health disparities might compare with health disparities in other places with caste systems like India?
So I actually haven't read Caste yet, although I've owned it for a while. But I will say that when I was in 2001, when I was in South Africa, with the UN held its World Conference Against Racism, Racial Discrimination, and Related Intolerance. So I was an unofficial, I wasn't there with the government or anything, but I was there in Durban. And Dalits were outside with signs that said, casteism is racism. And I took pictures of that, but I have since then said that no, racism is casteism based on the social interpretation of how one looks. So I actually, although I haven't read Dr. Wilkerson's book yet, I have recognized that for a while. So yes, but it's not about the social determinants of health. The structuring piece is really about the social determinants of equity. So the caste system, like racism, which racism is casteism, racism is casteism based on the social interpretation of how one looks, whereas in India, the caste system is casteism based on, family name, or, like just actual deep ancestry, not even an interpretation into it, but just like lineage. But they are the same structure. And what these social determinants of equity or inequity do is determine, I'm sorry, I know you hear something. We're just gonna let that go. I'm sorry. It's a weather system. Anyway, that what these systems of structured inequity, what they do is then they determine your social class, they determine your neighborhood, they determine your educational opportunities. So the structuring piece is at the social determinants of equity level, and then the actual context is at a different level. And so that's the distinction that I'm making with a cliff, and that's the distinction that I'll continue to make. That's why it's important for people to go beyond addressing the context to understand how did the context get structured that way, right? Like who was at the table, who was not, what is the system, what are the systemic pieces of it that are manifesting in different contexts and different people in different contexts? So that's an important question, and thank you. So I will now start sharing again. And so that first part was like framing the work. I guess I have to say that in that framing the work, even though a client might come to you and ask you to do this little piece and evaluate this little thing or whatever, you need to have and discuss with the client a deeper understanding. Because I often talk to medical students or physicians who themselves are busy trying to be the best ambulance, fastest, most efficient ambulance at the bottom of the cliff. We need ambulances at the bottom of the cliff. We need some of all of it. But even those need to wonder, is there a net above me? And how strong is that net? Is there a fence at the edge of the cliff? How strong is the fence? How close is the population to the edge? At what part of the cliff am I operating? And do I even do things the same way when I'm operating at different parts of the cliff? So it behooves all of us in our day jobs to wonder about different aspects of the system. And I'm glad I thought to say this. And as citizens, not in a narrow national sense, but as global citizens, as people concerned about the whole, I would say that the first thing that all of us in our private roles, in our citizen roles, should be concerned about is addressing the three-dimensionality of the cliff, no matter where our day job is. But for you all who are researchers and consultants, I would say that you could actually add value to what your clients bring to you by adding this greater context and understanding in the health context for example, and in all of these, we must be about understanding and addressing racism, sexism, heterosexism, and the like, the things that are structuring these three-dimensional cliffs. All of the cliffs that we're working with are three-dimensional. So that first part was like contextualizing the work. That's why we're doing this. Now, the next two parts about naming racism and then moving to action. There are 4 key messages when naming racism. The first is that racism exists. The second is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth is that we can act to dismantle racism. So I said I was going to bookend this with 2 allegories. This first allegory that I call Dual Reality, a restaurant saga, and most of my allegories are based on something I've seen with my own real eyes. This one was based on my experience as a first-year medical student. I'm about to share that experience with you. I will already tell you that the moral of this story is that racism exists. Okay, so here I am, first-year medical student, very diligent, very studious, wake up one Saturday morning, and I hit the books, and I hit them hard. And, I'm studying, it comes to be about mid-afternoon, and some friends come over. And do they distract me from my studies? Oh, no, we all get to studying long and hard. And now it's getting late into the evening, and we're getting hungry, and I have no food in the apartment, which was so typical of me that my friend said, never mind, Kamara, but we are hungry. Let's go into town and find something to eat. So we do. We walk into town and we find a restaurant and we walk in and we sit down and the menus are presented and we order our food and the food is served and here we are eating. So it's perhaps not the story about racism that you thought I was going to tell. But here we are eating. And as I sat there eating with my friends, I looked across the room and that's when I noticed a sign that was a startling revelation to me about racism. So now, perhaps I've intrigued you, and you're wondering, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said open. So now maybe I've lost some of you. So let me recap. Here we are, sitting in a restaurant eating. I look across the room. I see a sign that says open. Thinking no more about it, I assumed that other people would be able to come in and sit down and order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that indeed the restaurant was now closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food, and eat. And that's when I recognized that racism structure open, closed signs in our society, that racism structures, if you will, a dual reality. And for those who are inside the restaurant, sitting at the table of opportunity, eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. So, for example, it is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context. But those on the outside are very well aware that there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act. So that if you care about those on the other side of the sign, which is an if, but if you do, well, you could even talk to the restaurant owner who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money. And oh, the conversations we could have. Do a pass through the window. Or maybe you'll try to tear down that sign or break through the door. But at least what you won't be doing is sitting back saying, I wonder why most people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So I tell this story when I have about 4 or 5 minutes to convey to a group that yes, racism exists, is structuring two-sided or multi-sided signs in our society, is creating a dual or multifaceted reality. And in fact, of course, racism is not just the sign, it's the door, it's the lock. There's a whole system going on. And I actually started a 3-hour conversation once by asking the question, how could people born inside the restaurant know something about the two-sided nature of that sign? Always been there. And it was a 3-hour conversation because there are many ways to know. I am actually heartened that coming through 2020, there are more people who maybe in 2019, sitting inside the restaurant would have said something like, what are those people outside saying? Black lives matter? Don't they know all lives matter? Who are now affirming, yes, Black lives matter. There are more people who are putting together the words structural racism, systemic racism. This is very heartening. More, I don't know, apt associates may have put out a statement. Lots of people did, right? You saw there was an explosion. I didn't show you the timeline of those 30 states that have 176 jurisdictions, but it was quite an interesting timeline that exploded after the murder of Mr. George Floyd, right? So there are more people saying things. This is important because naming racism is essential, but it's necessary but insufficient. And racism denial is so staunchly held in this country and so seductive that if we just say a thing in 6 more months, we may forget why we said that thing and fall back into what I describe as the somnolence, the sleepiness of racism denial. So we must move into action. We need to tear down the sign, dismantle the lock, take the door off the hinges, because if we start acting, we will not forget why we are acting. So now I know that I owe you all a definition of racism because I've said it a bunch of times now. Hope none of you fell off your chair. And actually, I'm going to check my time. Okay, I think we're good. So my definition of racism starts with the observation that racism is a system. When I say the word racism, I'm never talking about an individual character flaw or a personal moral failing or a psychiatric illness, as some people have suggested, even though racism manifests in those ways. But in its essence, racism is a system of power. And a system of doing what? It's a system of doing 2 things, of structuring opportunity and of assigning value. And on what basis is the opportunity structured and on what basis is the value assigned? It's based on the social interpretation of how one looks, which is what we call race. And I could go an hour on that. I used to have an hour lecture on that, but I'm not going to stay there because I'm trying to be timely here. So what are the impacts of this system of structuring opportunity and assigning value based on so-called race? Well, when we do think or talk about racism at all, we understand that racism unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people, especially some people who are living as white, uncomfortable. And at this point in a talk, I used to apologize. I used to say to people, well, if you feel uncomfortable, I'm not trying to make anybody feel uncomfortable. Just shake it off. Stay with me. I'll tell you some more stories. I don't apologize like that anymore. If my talking about unearned white privilege, how racism unfairly advantages some individuals and communities, is making you uncomfortable, I encourage you to lean into that discomfort, because I have to recognize that for all of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism that many of us miss, and that is, even as it's disadvantaging some and advantaging others, racism is sapping the strength of the whole society through the way of human resources. So it's not just that Black Lives Matter, for example, it's that Black lives are genius. Black lives are leadership and creativity and generosity and love. And when we constrain Black lives and Latinx lives and Indigenous lives and Asian Pacific Islander lives and Native Hawaiian lives and all of these racialized lives, when we constrain these lives slowly by not vigorously investing in the full, excellent public education of all of our kids, because the blinders of racism have made some leaders think that there's no genius in the barrios or the ghettos or the reservations, we can get along very well, thank you, without those kids, then that's sapping the strength of the whole society, because of course there's genius in all of our communities. And if we were to only vigorously invest in that genius, we could be doing so much better as a nation or as a world. When we slowly constrain Black and Indigenous and other people of color lives by being complacent with the wholesale warehousing disproportionately of so many Black and brown folks in our prison system, as if that didn't separate us from human potential, we are cutting off our nose to spite our face. We need to understand, I think that this third impact of racism, how it saps the strength of the whole society through the waste of human resources, needs to be the message right now. All three are important, but we need to elevate this. We need to have more media stories about this. We need to have more data collection, more analysis, more conversations around our dinner tables, so that more of us are filled with a sense of urgency to dismantle this system and put in place a system in which all people can know and develop to their full potentials. Just want to say one more thing about that unfair disadvantage, unfair advantage piece. Because when I was working at CDC, that became like that. People started, they started saying I couldn't do talks if I was going to talk about how racism unfairly advantages other individuals and communities. In fact, we came to a truce at one point. If I took the word unfairly off of both disadvantage and advantage, then maybe I could keep saying stuff like that. And then I left CDC. But in the meantime, what that experience taught me was that there are many people in this country who think there are two states of being, yes, disadvantaged and normal. And the reason that people think there are two states of being, disadvantaged and normal, is that we in this nation are ahistorical. And people do not understand that their so-called normal is built up on a whole mountain of unfair advantage. I'd like to shift now then. So again, here I am, I'm a health person. I am going to talk about how I started thinking about how could racism turn into adverse health outcomes on three levels. But these three levels of racism, as you will see, apply across whatever sector is your main focus. Okay. But so when I was trying to understand how could racism turn into differences in the numbers of our babies dying before their first birthday, or the infant mortality rate, or the numbers of women dying within a year of being pregnant, the maternal mortality rate, or how did it turn into the differences in obesity prevalence and asthma prevalence and high blood pressure prevalence, all of these things, kind of the pre-existing conditions now that are making it more likely that once somebody is exposed to and infected with COVID-19, that they will die. How did it turn into these things, these differences by race? And so I talk about three levels of racism: institutionalized or structural, personally mediated, which some people call interpersonal, but because I know that racism is a system, instead of calling interpersonal, which means like maybe it's between people, I describe this level as personally mediated, the system mediated through people, and internalized. So I'm going to quickly define each of these levels, give you examples of how they can impact health, and then illustrate them with another of my allegories, my gardener's tale. Institutionalized or structural, I published this paper 21 years ago now, so I said institutionalized, but structural is interchangeable. Structural racism is the system, if you will. It's the system of structures, policies, practices, norms, and values that taken together result in differential access to the goods, services, and opportunities of society by race. So this is the kind of racism that does not require an identifiable perpetrator because it's been institutionalized in our laws and customs and background norms. It shows up as inherited disadvantage, or it's reciprocal inherited advantage. We see it in terms of material conditions, as well as in terms of access to power. So examples in the health side include differential access to quality housing by race, or excellent educational opportunities, or equal employment opportunities, or even the same level of income at the same level of employment. And clearly those things impact health, right? Differential access to medical facilities, not even financial access or physical access, but linguistic access. Differential access to a clean environment, and the very well-documented disproportionate placement of toxic dump sites or bus transfer stations in communities of color. And in terms of access to power as information, which could be health information, how do I sign up for a vaccine, right? Or even information about our own histories. It could be resources, not just capital resources, but social networking resources, or even a pharmacy in my neighborhood kind of resources, right, as power. It could be voice in media, voice in government, and the like. And sometimes when I have shown this slide in the past, and when we were in person, and say, excuse me, Dr. Jones, look at that first set of examples that we have. Housing, education, employment, income. Dr. Jones, isn't that what we call the social determinants of health? Isn't that what we call social class? Why do you have those things on a slide about racism? Are you talking about racism? Or are you really talking about social class? This is a very important question. So I will answer it. My answer starts with the observation that it doesn't just so happen that people of color are overrepresented in poverty, while white people in this country are overrepresented in wealth. That's not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. So for example, for American Indians, the initial historical injustice was the taking of the land. And then the near genocide, and then the moving of survivors to reserve lands, reservations, and then in some instances, something good was found under one reservation. Oops, you got to pick the people up and move them someplace else, right? We have people who for centuries lived in Mexico, never crossed the border, but the border crossed them. They find themselves in New Mexico and the like. And all of a sudden, their grandchildren, great-grandchildren are still being harassed and targeted in the El Paso massacre and the like, right? We have people who were brought over to this country to build our railroads, Chinese laborers, unable by law to bring their families, unable by law to marry. We have Asian Americans during World War II who were interned in prison camps, basically, while German Americans and Italian Americans were not so treated. For people of African descent, the initial historical injustice was the kidnapping of West African people and our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors and their progeny for generations and generations and generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then some people might say, oh, Dr. Jones, there you go talking about slavery. Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865, and we are now in 2021, which makes that 156 years ago. So all else being equal, Dr. Jones, don't you think the impacts of slavery would have washed out by now? But the key phrase, the answer is in their question. All else being equal. All else has not been equal since 1865. All else is still not equal today. There are what I describe as present-day contemporary structural factors that are perpetuating that and all of these other initial historical injustices. And these contemporary structural factors are part and parcel of structural or institutionalized racism. So when you ask me, am I talking about racism or am I talking about social class? My response is that structural or institutionalized racism explains why we even see an association between social class and race in this country. It is not just a happenstance. I just want to say one more thing, even though I'm trying to be careful with my time. And that is that sometimes when I talk about racism, people say, well, Dr. Jones, you don't really care much about poor white people, do you? And that is not the case. I care deeply about poor white people, poor Black people, poor Hispanic Latino people, poor Asian people, poor Indigenous people, poor Native Hawaiian, other Pacific Islander people, poor all kind of people. But I warn us, you know, like if you give me a magic wand and I could eliminate poverty today, boom, done. If I could hit it twice, boom, boom, and go beyond eliminating poverty to equalizing income today, I would do that too. My husband and I disagree, but I would do that too. But if even that, if I equalized income across races today, but did that without addressing the background structures, policies, practices, norms, and values, the mechanisms of institutionalized racism, then within one generation, we would start to see a stratification by race again in terms of income. This is not an either or anti-poverty or anti-racism interventions, emphasis, work. This is a both and. I also need to say before I leave this slide that structural racism can occur through acts of doing, acts of commission, as well as acts of not doing, acts of omission. And very often, structural racism shows up as lack of action, inaction in the face of need. So I'm going to have to just breeze through these other two levels of racism. Personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. This is what we think of when we hear the word racism. Somebody did something to somebody. It includes the different idea, the prejudice, and the different action, the discrimination, and has manifestations in terms of police brutality, physician disrespect, shopkeeper vigilance, and waiter indifference. You know, these are elements of, you know, everyday racism, the microaggressions, the subtle communication of disrespect, which might be related to elevated blood pressures in communities of color, blood pressures that don't even go down at night, teacher devaluation, and a teacher looks at a young child, thinks that child can't learn, and puts them off in the attention deficit disorder track, where that child will never even know their full potential, much less have the opportunity to develop to their full potential. Like institutionalized or structural racism, personally mediated racism can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. But even more important to recognize on this level is that this level can be unintentional as well as intentional. That is, you do not have to have intended to do something racist, to have had a racist impact. The third level of racism, internalized racism, I am defining here from the point of view of members of stigmatized races, where it's acceptance by members of stigmatized races of negative messages about our own abilities and intrinsic worth. I recognize that this internalized racism has the internalized oppression part that I've just described, as well as the internalized sense of entitlement that many white people walk around with. That is also internalized racism, but I don't have that sense of entitlement on the slide. First of all, because I never could figure out how could a sense of entitlement turn into bad health outcomes, although now maybe it is the fact that a sense of entitlement toward it is at the basis of what some people are describing in white populations as the diseases of despair, the suicides and the opioid overdoses and the like. But the rest of this slide is still from the point of view of members of stigmatized races, where internalized racism shows up as self-devaluation, feeling maybe I'm really not as good as, maybe I shouldn't try to graduate from high school or go to that college or get that job or live in that neighborhood. It turns into the white man's ice is colder syndrome, a phrase that I got from my parents, and in their generation, what it meant is still what it means for many people of color today. So that if I'm Black and I need a lawyer, I might seek out a white lawyer over a Black lawyer. If I'm sick, I might prefer the white doctor over the Black doctor if I could find a Black doctor. If my lemonade were warm, I might go way down the street to get the white man's ice over the black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. Internalized racism shows up as resignation, helplessness, hopelessness, which turns into a lot of self-destructive health behaviors. And in its essence, is about members of stigmatized races accepting the limitations to our own full humanity of the box into which we've been placed, where violin is not a black instrument, for example, or where young high school students of color, where one of the friend group is trying to be the valedictorian, might tease her or him by saying, well, so is trying to be white. We need to challenge that kind of stuff. Since when did, excellence, when did white people have exclusive access to excellence? They do not. So now I'm to illustrate these three levels of racism with my Gardner's tale allegory. So I'm going to stop sharing because, as you see, I use my hands a lot, and I want you to focus on this right now. This allegory, like most of my allegories, is based on something that I've seen with my own real eyes. So let me tell you the story that prompted the allegory. Then I'm going to make it a story about these levels of racism. So my husband and I have been married about a year. We went back down to Hopkins, where I was going to finish my PhD. We bought our first freestanding house, cute little house, big wraparound porch with flower boxes dotted all on the porch. And we bought this house in October, which was not the time to plant in Baltimore, so we waited. But when spring came, my husband, who loves to garden, he ran out with our marigold seeds, going to decorate our cute little house, right? And then he came right back in. He said, well, Kamara, some of these boxes have dirt in them, but some of the boxes are empty. I need to go down to the gardening store. So he does. He goes to the gardening store. He comes back hauling big old bags of potting soil, and then we fill up those empty boxes. And then we take equal numbers of our marigold seeds and put them in all the boxes. And we water all of the boxes equally. And by this time, because I am not the gardener in the family, I'm exhausted, right? I'm going to sit back and be delighted. Well, about 3 weeks later, as I'm walking out of my front door, I finally pay attention to these flower boxes. And what I saw made me literally stop in my tracks. Because what I saw made me think we had planted completely different species in some boxes versus others, because some of the boxes were full of plants and they were tall, vigorous looking plants. And some of the boxes just had a few plants in them. And they were kind of scrawny and scraggly looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil, so that all of the seed planted in the rich, fertile soil sprouted. The strong seed grew very tall and vigorous, but even the weak seed made it halfway up. But that old soil that we found there turned out to be poor, rocky soil. So the weak seeds planted in the poor, rocky soil just died, and even the strong seed in the poor, rocky soil had to struggle to make it to a middling height. And maybe you guys are nodding, some of you, because maybe some of you are gardeners, and maybe you've composted half of your garden, so maybe you've seen this image with your own real eyes. And of course, the image is about the importance of the soil, the importance of the environment. But now, I am going to expand on this image by introducing a gardener. So now we're going to have a gardener who has two flower boxes, one which she knows to have rich, fertile soil, one which she knows to have poor, rocky soil, and she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms, and some of the seed is going to produce red blossoms, and the gardener prefers red over pink. So what does she do? She takes the red seed, puts it in the rich, fertile soil, pink seed in the poor, rocky soil. And 3 weeks later, she sees in her flower boxes what I saw in mine. In the rich, fertile soil, all the red seed sprouts, strong red seed, tall and vigorous. Even the weak red seed makes it halfway up. In the poor, rocky soil, the weak pink seed dies. Here comes a strong pink seed, struggling to make it to a middling height. And then in those flower boxes, those flowers go to seed. And then the next year, the same thing happens. And then those flowers go to seed. And then year after year after year after year, the same thing happens until finally, about 10 years later, the gardener's looking at her flower boxes and she says, you know, I was right to prefer red over pink. So we're going to interrupt the story here to say the first part of this story is how structural or institutionalized racism works, where you had the initial historical injustice of the separation of the seed into the two types of soil. You had the contemporary structural factors of the flower boxes, keeping this soil separate. And then through lack of action, inaction in the face of need, perpetuation of the inequity. But let's pick the story back up to say, well, where is personally mediated racism in the garden? Well, the gardener's looking at her red flowers and she's thinking, oh, those flowers are so beautiful. And then she looks at the pink flowers and she says, oh, those pink flowers sure are scrawny and scraggly. So she plucks off the pink blossoms before they can even go to seed. Or maybe she notices that a pink seed has blown into the rich, fertile soil. And so she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in this garden? Well, the red flowers are just living their lives, enjoying being red, many of them not acknowledging or perhaps not even recognizing that they are benefiting from enriched soil. The pink flowers are looking over at red, thinking red is mighty fine and wishing with all their hearts that they too could be red. And here come the bees, minding their own business, collecting nectar, but pollinating at the same time. So bzz, here comes a bee into one of the pink flowers, and then bzz, to another pink flower, and then bzz, to this pink flower. And that flower is like, get away from me, bee. Don't bring me any of that pink pollen. I prefer the red because the pink flower has internalized that red is better than pink. So now our question arises, what do we do to set things right in this garden? Well, we can start by addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink, which is an important intervention. But if that's all we do, it's not going to change the situation in which they find themselves. Or you might say, okay, got that. Let's address the personally mediated racism. Let's have a conversation with the gardener, or better yet, let's have a workplace multicultural workshop for the gardener. All good. So we have our workshop, and in the workshop we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, and maybe she won't, but even if she does, it's still not going to change the situation in which the pink flowers find themselves. If we really want to set things right in the garden, we must address the structural racism, which means we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier for that same gardener to continue segregating resources going forward. But if you keep separate boxes, it means you must enrich the poor rocky soil until it is as rich as the rich fertile soil. And when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious, so that in the intervention on the structural racism, you will have also addressed the internalized racism, because now pink will not be looking over at red, thinking red is better or wanting to be red. And in the intervention on the structural, you may also address the personally mediated racism. Now, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful will be less likely to have that kind of attitude, right? So with this story, I have illustrated 3 levels of racism and strongly suggested that if we want to set things right in the garden, we need to at least address the structural racism. Good to address all the levels at the same time, but at least address the structural, and the other levels may take care of themselves. But there's one more question that we haven't answered yet, which is, who is the gardener? After all, the gardener is the one that I gave power to decide, power to act, and control of resources, which are actually the elements of self-determination. So who is the gardener? Well, government's a huge part of the gardener, but not the only part. Media, foundations, corporations, maybe you guys as a think tank, communities to the extent they have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red, that's why she prefers red over pink. And it's also dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers to be part of her garden. So now the question arises, what do we do about the gardener? Do we make the gardener striped or polka dotted or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Lots of questions that can come out of this story. I actually want to share 2 with you, and then we will open it up for just a very brief, 1 or 2 questions, and then I'm going to wrap with the last piece. But these questions, this first question, I was asked early on when I started telling this story, and I carry it with me everywhere. The question was, excuse me, Dr. Jones, but why should the red flowers share their soil? I heard that question. I loved that question because it showed me the power of this story to start conversations about racism that might be otherwise difficult if we're talking about racism between you and me. My answer to that question, why should the red flowers share their soil, is that actually, that soil doesn't belong to the red flowers. It belongs to the whole garden. Here's a second question. What if that's not the original gardener we're looking at right now? What if that's the gardener's great-great-great-great-grandchild? Here we are. And that great-great-great-great-grandchild has always seen the flowers looking like that, may not even think there's a problem. So very quickly, in 3 steps. 1, we must make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. Two, in order to get to the solution, we must make the flower boxes transparent. We must be talking about the differences in the quality of the soil so that we can address those differences. But number three, as we make those flower boxes transparent, we also need to communicate to everyone that the pink seed did not just go launch themselves into that poor rocky soil. So we must talk about how the gardener's initial preference for red over pink set up the situation. We must talk about history. We must talk about that, what some people in our context, some people call it cultural racism. In our context, it's white supremacist ideology. We must talk about that, because if we do not, even if we were to compel that gardener to enrich the poor rocky soil today, until it was as rich as the rich fertile soil, if she continues to prefer red over pink, she will continue to privilege red over pink going forward. We must address not only the opportunity structures, but the value assignment if we're going to set things right in this garden. So we are now just a very brief pause for discussion. I'll stop sharing. And I guess I want to take up to 2 questions, because there's so much more I want to share with you guys, but I would like to hear at least 2.
Okay, thank you so much. We have a lot of questions, but I think one that's really interesting that came up is, so what can we do so what does taking actions look like, specifically for a for-profit organization like APT? This may not be unique to APT, but how can we as an organization even address our own institutionalized and internalized racism as we seek to compete for funding to dismantle racism everywhere?
That's a beautiful question, and that's why I want to rush to the third part. It's right there. The quick answer is we need to go from naming racism to asking, how is racism operating here? Looking at different elements of decision making. So I'm going to share that framing for you, and then I've done it for a generic research and consulting firm. So hopefully some of those ideas might ring true for APT. So yes, I'm going.
Okay, so second question, I think I'll also try to condense some that came up. A lot of people ask about how to dismantle racism, or like make sure that our education of public healthcare and medical clinical education, and also in academia, like how do we make sure that people are educated and trained to work against racism there? And on the other side, as a patient, what could we do when we interact with the healthcare system? And I think this is both right as a white patient, but also as a Black patient or a patient of color. How can we address racism that we encounter when we interact with healthcare systems?
This is very important. And it's especially important right now in the context of COVID, where we're often alone interacting with healthcare systems, right? Because part of the answer would be like, bring your posse, like don't be in a hospital bed by yourself, like you need people to have eyes and ears for you. But one of the things that I find in any setting is to, first of all, each of us needs to be able to recognize racism when it's happening, because a lot of people walk through the world and think that there's no racism happening. And a lot of us understand that it is. And people would even say that we were too sensitive, or we have a chip on our shoulder, when actually we're just observing the world and what's happening. So, so for those who recognize and those who don't, we have to honor when somebody says, this thing just happened. To me, it's the open close sign, right? And we could be feet away from each other in the same air, in the same space, but have very different experiences, real experiences, and even different awarenesses of what was going on and what the meaning of the sign is that we just saw. But I find that, so once we get this awareness, if you're a white person and you're aware, then often you can use your white privilege to call it out even more easily. Like if you come up to a counter after somebody who's a person of color who's been waiting there, but then they ask to take care of you first, you should say, no, this other person was there first. I mean, so declining privilege is a way for white people to sort of acknowledge racism, but also to ask the question, why did you say that? What did you mean by that? Or to call something out. I don't know if you noticed that you just did such and such. So it's to shine the light on the actions and to say this thing happened, and not to say you were a racist dog when you just did that, but say, why did you do that? What did you mean by that? Were you aware of this? Because yes, this thing just happened. So that's like at a very personal level, a way to respond. But as this next story is going to be about, is all of us need to recognize that yes, racism often manifests in interactions, but the more silent thing, the inaction in the face of need, which is how structural racism most often manifests, we need to start being able to recognize that as well. So instead of saying, oh, you know, this community, blah, 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 well, then do something about it. You know, like start action, and the action has to be collective action. Sometimes we're so narrowly focused on the individual, we ask, well, what can I do? And we throw up our hands and maybe I'll read a book, you know. But the question is not appropriately, what can I do? It's what can we do? Because working collectively gives us power, it gives us protection, you know. So that's, I'm going to talk a little bit more about all of those things, but that's my quick answer. And so now I'm going to, even if you have another question, I recognize my time, so I'm going to just speed on, and hope we have enough time to answer about, oh, it would be great if we had 10 questions at the end, but I do want to get through the rest of this. So getting back to my slides. So this third part, so the first part was kind of framing why racism in the work and all like that. What is the work about, and why do we, you know, the three-dimensional cliff. The second part was tools for naming racism. I gave you the dual reality story. I gave you the Gardner's tale. I gave you a definition and levels, all of that. This third part is moving to action. So this is the newest allegory that I have illustrated. I've probably said it about 20 times, but this is just the second time I've said it with these illustrations. And the first time those people haven't even seen it yet because it's going to air in a week. So forgive me if it's clunky, but this cement dust in our lungs, I am sharing to get across the message that racism is a system, and that we need to understand and address racism as a system. So imagine that there's a cement factory spewing cement dust. And if you're anywhere near this factory for any amount of time, you're going to get cement dust in your lungs. And this cement dust in our lungs is problematic for all of us. Now, it might affect some of us differently from others. So the cement dust in my lungs might make me feel like I'm less than, whereas the cement dust in somebody else's lungs might make him feel like he could crush the life out of another human being by putting his knee on their neck 8 minutes, 40 seconds. But it's problematic for all of us. So recognize that, you know, the cement dust is in our lungs and it's problematic. Some of us don't recognize it yet. But what are we going to do? Are we going to focus on the individual? That's one strategy. So what might that look like? Well, maybe we could have some kind of screening machine, and we could screen people for how much cement dust do you have in your lungs. And then if we find somebody with too much cement dust, and maybe, you know, we vote them off the island, or we brand them or something. This is not a good idea, because this is what makes many people hesitant to even say the word racism, right? Because they think that people are looking at them trying to divide a room into who's racist and who's not, or look deeply into their soul and say, exactly how racist are you? So I don't think this is a useful tack. But what else could we do? Still focusing on the individual. Well, maybe we set up some cleansing spas, right? So maybe if you feel like, oh, I can really feel the cement dust in my lungs and I'm not liking it, maybe you can go into the cleansing spa, right? You do a little training, or 3 or a week or a month, and you come out and you're as good as new, but then you come back into that same dust and you have cement dust in your lungs again. Not a very permanent kind of solution. So do we focus on the climate, the dust in the air? Do we focus on that? Well, yeah, we need to at least acknowledge that the cement dust didn't just appear in our lungs, that we have breathed it in. So maybe if I don't want more cement dust in my lungs, maybe I'm going to put on a gas mask, right? So now that gas mask is not going to extract the cement dust that I have in my lungs, but it's going to keep me from having more cement dust in my lungs. And it also does another thing, because every time I see myself reflected in a glass or a mirror, I'm going to remember I'm living in this big old cloud of cement dust, right? You know, so the gas mask is really the start of my individual anti-racism journey, right? That's what that is. And when you see me with my gas mask on, you might say, Laura, why are you wearing, Dr. Jones, why are you wearing a gas mask? And I'll say, there's cement dust in the air. And now more and more of us are going to put on the gas mask, right? More and more of us start our individual anti-racism journeys. But is that sufficient? Do we need to make lots of gas masks, little baby-sized gas masks and old people gas masks? And is that what we're supposed to do? I would say, no. What we need to do is focus on the system. So now especially those of us with our gas mask on who understand there's this whole thing, we need to move into action. We need to get closer because the cloud has obscured the fact that there's a system even going on. We need to get closer to the cement factory that is spewing the cement dust. We need to ask the question, how is racism operating here? We need to shut the factory down and then put in its place a system in which all people can know and develop to their full potentials. So this is my little story to illustrate that really what we need to do is focus on the system. Racism is a system, and these other interventions are short-termy, but what we really need to do is focus on that. So I said that what we need to do at the end is ask the question, how is racism operating here? That is a legitimate question because racism is not a cloud, a miasma. It's a system with identifiable and addressable mechanisms, which are in our structures, policies, practices, norms, and values, which are different elements of decision-making, right? Where structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And whenever you are at a decision-making table or setting one, I encourage you from henceforth to take, your first job is to look around and say, who is not here at this table who has an interest in this proceeding? And then in the short term, you might try to represent their interest, but in the long term, you need to create space. You need to find them a way to the table. The structures are the who, what, when, and where of decision-making. Then policies are the written how of decision-making. Practices and norms are the unwritten how of decision-making, and values are the why. And so I encourage us to take this question, how is racism operating here with us everywhere? How is racism operating at my child's daycare? How is it operating at my workplace? How is racism operating here with regard to the police killings of unarmed Black and brown men and women? How is it operating here with regard to the disproportionate impact of COVID-19 on communities of color, or the underrepresentation of Black folks in clinical trials, or whatever? I gave my hand at how is racism operating here in a generic research and consulting firm. So you guys might say, oh, Kamara, you are way off, or whatever, but we ask this question so we can identify levers for intervention, targets for action. So I offer up these next ideas as things that you could think about, but actually I think that the whole exercise of asking how is racism operating here is another useful exercise for you all as teams or as leadership or whatever. So identifying mechanisms. Well, with regard to structures, limited diversity of perspectives and lived experiences on boards of directors and in top leadership, that is often, no matter what kind of generic or academic health centers or whatever I'm talking about, that's a structural way that racism most often operates in most places, right? In terms of policies, the written how, so limited networks for recruiting new employees, or discretion in offering opportunities for staff advancement. This is a subtlety here, because if a policy allows for discretion, so then people can act out their own biases. There is a relationship between structural or institutionalized racism and personally mediated racism. Of course, institutions act through people. People's actions are condoned by institutions, and the institutional policies that allow for discretion in who gets, I don't know if you guys, like at CDC, they had long-term training where you could get, you could apply and get your PhD in, while you were working there. I don't know if you guys have that kind of thing, but when discretion enters into who can get this versus the other, that's where you start seeing a lot of personally mediated stuff come in. It's not that the institution did the thing, it allowed the thing because the policies allowed discretion. It's a subtlety. I hope I wasn't confusing there. Practices of derailing conversations about employee experiences of racism. Well, that didn't really happen, or even hesitation to take initiatives beyond client specifications. So if a client engages you and it's about such and such, and then you're thinking, well, maybe we should start collecting data by race, ethnicity, or maybe we should collect data by zip code, or maybe we should by whatever, and hesitation to even broach that to the client, or even to do that work, which is not going to derail, it's going to enhance the work. That kind of hesitation is a practice that often directly impacts the work and is about racism, not only in, because these things are about racism and who you are and racism and what you do. So that's sort of racism and what you do. Norms, including prioritizing intent over impact. So something happens. A comment is made in a meeting or whatever. I'm just speaking out of my own experience now. And then I say, well, that was inappropriate, it hurt me or whatever. And somebody says, oh, well, I didn't mean anything like that. Yeah, but it doesn't matter what you meant. A narrow imagination for what genius and leadership look like within an organization, and not offering opportunities or seeking out the input of people marginalized because they don't look like your roommate in college 20 years ago. And racism denial, which is, as I said, normative in the whole US. I'm starting, the edge of my work right now is thinking about racism denial as the black hole in our universe. That racism denial has so much mass, but you can't see it and it's just sucking things in. So that's a norm throughout all organizations. And then the values of the narrow focus on the individual and a historical stance and myth of meritocracy that I already talked about a little bit in the context of the cliff analogy, but I'm coming because I'm going to tell you all 7 of my barriers to achieving health equity. And also comfort in the status quo. Sometimes the status quo is a value thing. It's not good. It's not good. The edge of our comfort is our growing edge. So I'm going to shift just briefly to what is health equity. This is my 3-part definition of health equity. What is it? How do we get there? And how is it related to health disparities? This is related to the Healthy People 2020 definition of health equity, which I helped write, but it goes beyond it. I'll tell you what the distinction is. So I define health equity as assurance of the conditions for optimal health for all people. Healthy People 2020, that definition started out, health equity is attainment of the highest level of health for all people. I agree that that's our goal, but I think that this is not a good definition of health equity because what if we hit that last Sunday? Are we done? And health equity, in my conceptualization, is not an outcome, it's a process. Which process? Assurance, which is actually one of the 3 core functions of public health identified by the Institute of Medicine, along with assessment and policy development. Assurance of what? Of the conditions for optimal health, the social determinants of health, for whom? For all people. That's what makes it equity. How do we get there? Well, achieving health equity requires at least these 3 things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. Not equally, but according to need. When you value people equally, then you provide resources according to need. And then how is health equity related to health disparities? Health disparities will be eliminated when health equity is achieved. Health disparities are differences in outcomes. Counting the different numbers of different colored bodies at the bottom of the cliff, or counting the differences in the height and vigor of the pink and red flowers. Health equity is all the stuff that came before. If you are wondering whether your work or your client's work is about health equity, focus on, are you valuing all individuals and populations equally? And when you think, how do you value people? Think about how you might value your child by investing in protecting, nurturing, celebrating, inviting their voice, all of these things. And when you value folks, you value them in an unconditional way without even wanting this return. When you value people, think about, we could generate 100 words for valuing when thinking about how we value our children. Recognizing and rectifying historical injustices, which first of all, needs to be, do you know your history? Do you know the history of your institution, the city where you are, the state, the nation of this work? And then moving to rectifying those injustices, and then providing resources according to need, which you operationalize by first agreeing broadly on a metric of need, which might be the death rates from COVID-19 in different communities, right? Or it might be infant mortality rates or whatever. And then when you get resources, providing resources according to that metric of need. We obviously are not doing that with regard to vaccine distribution in this country right now. So we are so far off from equity when we see that communities of color are disproportionately impacted by COVID-19 deaths, and yet they are underrepresented, not only from their impact level, but even from the level of the population among those who've already been vaccinated. So here we are now to what I have described as 7 barriers to achieving health equity. I used to call them 7 social, societal, cultural barriers to achieving health equity. Then I recognized these as the 7 values targets for anti-racism action, because, you know, if racism is a system of structuring opportunity and assigning value, we understand a lot of the opportunity structure targets for action, you know, how we fund schools, what about housing, what about the legal system and all, but these values targets have been almost invisible, right? And now I call these the 7 social delusions that undergird racism denial, but I didn't put that on my slide. The first 3 I already talked about a little bit, but here's a more in-depth on these. The narrow focus on the individual makes systems and structures invisible or seemingly irrelevant. It makes us define our self-interest very narrowly. We don't even count our cousins and aunts and uncles as part of me, much less the people who live across town. It gives us a limited sense of there, but for the grace of God go I. We are all in this together. I am my brothers and my sisters' keeper. This limited sense of interdependence and a limited sense of collective efficacy. We wrongly ask, what can I do, when the more useful question is, what can we do? The second, this ahistorical stance, the fact that we act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. When you are ahistorical and you are born and things were a certain way, you think things have always been that way and will always stay that way. So it even limits our ideas about how we can make change. It makes systems and structures seemingly immutable. The myth of meritocracy, the story that goes like this: if you work hard, you'll make it. We already talked about how there are many people working just as hard or harder than those who have made it, who will never make it because of an uneven playing field, which is structured and perpetuated by racism, sexism, heterosexism, all of these systems of structured inequity. When we deny racism, we are endorsing the myth of meritocracy, blaming people who haven't made it for being lazy and stupid. And there are many ways to deny racism. One is to say, I don't think racism exists. Another is to never say the word racism. Even if you're talking about diversity, equity, inclusion, belonging, cultural competence, structural competence, disproportionalities, disparities, race, you could talk about all that stuff. But if you talk about all that stuff without saying racism, in the context of our widespread racism denial, you are complicit with that denial. The myth of a zero-sum game, if the story that goes something like this: if you gain, I lose, which sets us up in competition with one another over cooperation. It masks the cost that these systems of structured inequity, that racism saps the strength of the whole society. It hinders efforts to grow the pie. And in fact, it's like I'm sitting at a potluck dinner. I see you coming. I don't want you anywhere near the table because I think you're just going to come and eat all the food. I don't even recognize that you're bringing all kinds of cakes and pies and roasts and salads and fruits with you because I don't even value you. The fifth of these 7 is our limited future orientation as a nation. Now, the parts of the future that we can touch today are the children and the planet. In this country, we have a disregard for the children and a usurious relationship with the planet. We do not, like many American Indian nations do, have a 7 generations hence view when in our decision making. We don't think about the impacts of our decisions in 100 years. Nor do we, like I'm told Maasai people do in East Africa, greet one another with the question, how are the children? They don't say, hey, how you doing? They ask, how are the children? And the answer they hope to get back from you is, all the children are well. We don't even ask, how are the children in this country? And if we did, we would not get the answer, all the children are well. We don't even think about all the children. We think about my children versus your children without recognizing that all children are our children. And as I said, we have a usurious relationship with the planet. The 6th of these 7 is the myth of American exceptionalism. The story that goes something like this: the US is so unique, so ordained by God that the usual rules shouldn't apply to us, and that there's nothing we can learn from other nations. Oh my God, if we had only asked a few other countries how they were dealing with the COVID-19 pandemic, hundreds of thousands of lives could have been saved. The 7th of these barriers is white supremacist ideology, which I do not lift up as a lightning rod term. It is the term that describes this false idea of I would say, a hierarchy of human valuation by race. There is no such hierarchy, but the false notion that even if there were such a hierarchy, that would put white people at the top as the ideal or the norm. But this false idea gives many people who are living as white a sense of entitlement. It has resulted in the devaluation and indeed dehumanization of people of color, and fear at the browning of America, which underlies a lot of our political divide today. So what can we do today? Well, going back to that image of the open close sign, we need to actually look for evidence, actively look for evidence of two-sided signs. Is there something differential going on here by race, by immigration status, by gender, by language, by zip code, by urban, rural, by religion? We need to shine the bright light of inquiry. Is there a two-sided or multi-sided sign going on? Being unafraid even in our own practice, in how we do things within our employee group, looking not just at outcomes, but also at opportunities. We need to burst through our bubbles of experience to experience our common humanity. Each of us is in a bubble of experience. Some of the bubbles are big within soap bubble boundaries. Some of the bubbles are smaller with thicker plexiglass boundaries. Some of the bubbles are tinted or, polarized, but whatever kind of bubble each of us is in, of our children, our work, whatever, most often we do not know that just across town, there are people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to create, as individuals and as institutions, bubble bursting opportunities so that we can burst through our bubbles, experience our common humanity in different settings, and then start building common cause. We need to be interested in the stories of others, believe the stories of others, and then join in the stories of others. And I am heartened that through all the mobilizations in 2020, that was manifest. We need to develop a sensitivity to see the absence of who is not at the table, what is not on the agenda, what policies are not in place that if put in place could have a very beneficial impact. We need to reveal inaction in the face of need, because that is how structural racism most often operates these days. Doesn't require an identifiable perpetrator, just the system just doing what it was set up to do. And often, because we are inactive in the face of need, we're complicit, I would say. But all of the power and all of the action is not just on the side of those inside the restaurant. Those of us on the outside need to know our power. We need to recognize that action is power, and especially that collective action is power. So I'm looking at my time and I'm already over. So I will say that there was another allegory that I was going to tell, but you can Google my TED Talk to try to find that. That one was called Life on a Conveyor Belt, Moving to Action. And I did want to just run through this review by the numbers of the primer, and then if you want to stay on, I'll answer questions for another several minutes. But all of these things that are around this octagon are things that I shared with you all today, all except the last, and I will share it as I close. So 3 tasks for a national campaign against racism. And it would be lovely if you would try to, like in your own home, shout out and see if you remember them. The first was to name racism. The second, to ask, how is racism operating here? And the third, to organize and strategize to act. There were 3 different dimensions of intervention, health intervention or whatever, along my clip. Curative and preventive services, addressing social determinants of health, and addressing social determinants of equity. There were 4 key messages when I talked about naming racism. Racism exists, racism is a system, racism saps the strength of the whole society, not just through the waste of human resources, but really also by how it's dividing us one from another, and also dividing some people from their own self-interest. And finally, that we can, and I would add that we must act to dismantle racism. I identified 3 levels of racism: institutionalized or structural, personally mediated, and internalized. I identified 3 principles for achieving health equity: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. I identified 7 barriers to achieving health equity: our narrow focus on the individual, our ahistorical stance, our myth of meritocracy, the myth of a zero-sum game, our limited future orientation, the myth of American exceptionalism, and white supremacist ideology. I identified 6 actions just in the last thing I did with the open close sign, which are to shine the bright light of inquiry. I would say, look for evidence of two-sided signs, burst through our bubbles to experience our common humanity, be interested, believe, and join in the stories of others, see the absence of, reveal inaction in the face of need, and know that action, and especially that collective action, is power. So the parts that I didn't share with you are my 4 charges, and I've often used these in commencement addresses. I call them the 4 BCs, and I can't go deep on them, but the first is be courageous, be a truth teller. The second is be curious, ask why, and then why again, and why again. Ask serial whys to go from individual level explanations to root causes. The third is be collective, care about the whole. And the fourth is build community. So talk to a stranger, you know, be interested, believe in, and join in the stories of others. Go across town, not just for a quick visit, but go across town and stay a while. So with that, I am going to stop sharing, and I'm free for a bit so I can answer questions for those of you all who are able to stay on.
Thank you so much, Dr. Jones. I think we have a bunch of questions here in the chat. So one that just came up was asking about, the person said they feel since last summer there is a tension between promoting slower institutional change via policies and practices versus making faster, more urgent changes to dismantle systems. What are your recommendations how we act within these tensions to dismantle systemic racism?
Do all of it. Do all of it. All of it. All of it. We don't have to choose. There are enough of us to work in different ways. And so sometimes this is an interesting tension. Sometimes people want to get to low-hanging fruit, right? They want to pick the low-hanging fruit. But if you're always just picking the low-hanging fruit, you're never going to get to the root of an issue. It is so tempting to only do low-hanging fruit stuff and not start the action. Even my husband, who's the gardener, right? There's this tree that I want us to plant. And he's like, but it's going to take so long. And, you know, we're going to be so old, you know. And I'm like, you know, let's plant acorns so that our grandchildren can have shade. So we need to start doing those long-term interventions and those long-term slogging changes, right? Not that we're going to see the input, but that we pass the struggle on to our children, and they may have to pass it on to their children, but we start the thing rolling. If we never start with the long stuff, then it will never happen. I have 4 policy priorities in my national campaign against racism. The first is reparations to descendants of Africans enslaved in the US, as well as making good on all of the treaties that we've been, like, you know, not fully honoring in terms of indigenous peoples here. The second is decarceration or abolition of prisons. We can talk about different manifestations of that. The third is massive investment in communities of color, kind of a Marshall Plan, investments in communities of color around housing and environmental cleanup and green space and nutritious foods and banking and you know, schools and you know, wealth building and all of that, right? And the fourth is massive investment around our children, all of our children and their families, right? So that we will know the impact of these 4 things when the phrase disadvantaged child will be inconceivable. It will have no meaning. We won't even be able to imagine a child born into disadvantage or falling into disadvantage. So those are my 4 policy priorities. But I do have to say that even for foundations or politicians and all, most people want credit for an intervention that they started. So they want a 3 to 5 year timeline in terms of outcomes. What we need to do is being willing to invest in changing opportunity structures. We can measure the differences in the short term in how the opportunity structures are changing, but the outcomes, we may not see a difference in outcomes for a generation, for 20 years. Imagine, going back to my gardener's tale, that you have a pink flower that has grown up in this poor rocky soil. And now you're going to enrich the poor rocky soil until it's as rich as the rich fertile soil. And that pink flower might grow up another 1/4 inch. But it won't be until that flower goes to seed and those pink seed fall into the rich fertile soil that you will really see the impact of your intervention. We have to be patient like that. And we have to stop. I know it was just one question, but I just want to go one more bit of riff on this because I'm thinking that the way that we've been documenting the impacts of racism on health in this country is almost like we're doing, you know, what they call the Tuskegee study, the Tuskegee, sometimes we call it experiment, all of that's wrong. Really, the name of that study is the United States Public Health Service study of untreated syphilis in the Negro male. But anyway, that study, we're doing a thing like that, a natural history thing with regard to racism and health. We keep documenting the heck out of it, right? What we need to do is put a little penicillin in there, which is about investment in our communities and in our people and in our children and in our wealth building. That's what we need to do. And then look at the outcomes of that investment in a generation.
Thank you. Do we have time for another one?
Yes.
Okay.
No, I can't be so long on that one.
So one that came up a lot, starting from the beginning of the talk, there were several questions, but I think to summarize them was, and I know this is a really big question, but people asked, how do we talk to people at our work, our family, our friends who don't believe in like the three-dimensional cliff or the meritocracy myth, like people who believe that there's a meritocracy system, people who don't believe in unequal access and systemic racism. Do you have any advice on that?
Yes, so it might be hard, but what you need to do is have those people go across town and stay a while. You have to have those people talk to people who are not in their circles. My allegories help a lot. So you could refer them, the 18-minute, my TEDx Emory talk in 2014 has 4 allegories. I gave you the dual reality and Gartner's tale in there. There's another one that's Japanese lanterns, color perceptions, and then another one that I was going to tell you, the life on a conveyor belt, moving to action. And then there are other, so my allegories, that's a good starting place. And then if you start Googling me, you can start, share my papers and stuff. There's the cliff analogy was done in a shorter version by the Urban Institute as a whiteboard video. So I condensed my script and I narrated it, and they did a whiteboard video and they have a little cartoon me in it. So that, so there are resources out there like that. But the main thing is if their church has a partner church across town, or if there's some way that people can get out of their bubbles, what really happens is that most often, even when we're comparing ourselves to other people, we only compare ourselves to those who have more. And we never compare ourselves or even encounter often those who have less. So it's for people to burst through their bubbles and for us to create bubble bursting opportunities. Because once they start getting to know somebody who's living in different circumstances, then maybe they can start seeing through their eyes.
Okay, thank you. And we're sharing the links to those great videos on the chat as well. One other question that came up a bunch of times, because we have a lot of people here joining internationally and who work in international contexts, specifically also global health. And there was a question about, so the work is built on power dynamics, and those power dynamics are obviously built on white supremacy and systemic racism. How do for people who work in global health and international work, what are ways for them to dismantle that system while they also work within that structure that's built on these power dynamics?
It's a very hard question because, yeah, a lot of folks who are doing that international work, and it's sort of interesting because international work gets you to bubble burst, right? Because especially if you're placed internationally, then you understand that there's not just one way of doing things, and there's not even just one right way of doing things, and you meet people who are very different. But often when you're put in those settings, then you come with that power, with that money, with that whole thing. So the thing would be to recognize that and to share the power around, to not be content to go in there as the expert, but to find out from the people who've been trying to solve their problems on the ground for years, decades, invest in them and invite their voices to decision-making tables. So if you come in with some power and you're like, oh, this isn't right, then share the power to the greatest extent. It might shake things up. People might be like, oh, you can't have that person weighing in on this, but just do it, try it, push the system. Don't value the status quo. Remember I said that was one of the values that often we have, comfort in the status quo. Push against those things, especially if you have the eyes to see it. Sometimes when we are the ones who are benefiting from that esteem and whatever, when we're the ones that people stand up and offer us the seat, we think we deserve it. We're inside that open sign, or we feel deserving. But if you recognize that you're getting some kind of privilege because of that, refuse the privilege. I said that before, so I think I need to make that a tweet in some kind of way. But yeah, refuse or decline the privilege.
Okay, thank you. Yeah, I'm wondering, what's the time? Do we have time to take another one?
So as far as I'm concerned, I have to see. I can take 15 more minutes of questions. I'm here for 15 more minutes.
Maybe we
Okay.
should take one more, Amanda,
Okay.
and then
Yeah, because I think people are starting to drop out.
Okay.
So I saw one, I think that connects good to the one that you just explained, and it's kind of a very concrete one. As healthcare professionals, but also as people working in policy consulting, what can we do in diversity, equity meetings, inclusion meetings to address complicity to racism?
First of all, I would encourage all of you guys in all of your settings, when the thing is called, diversity, equity, inclusion, whatever it's calling, saying, let us also explicitly be anti-racism. I don't even say anti-racist, because if you say anti-racist, people think, oh, you're against people. And of course, I'm clear that racism is a system. It's not about the people. So, but you could ask, so one thing is to start naming anti-racism in your committees and in your work. And then, but you just can't name it. You got to move to action, right? Because if you just name it, you might in 6 months forget, well, why did we say anti-racism? And the work is involving, it's about power sharing. It's about power sharing. So if you're working on something, invite the community voice on that thing. If you're doing an evaluation, what does the community say about whatever it is you're evaluating? If you have resources and you can invest in something, don't invest in the new startup, whatever. Find out, well, who out there has been doing this work for a while, and invest in them. Diversify, invite to decision-making tables, and go and see if you can be invited so that all the decision-making isn't at your table. See if you can learn something, just be a fly on the wall, even without power, and go, like I said, go across town and stay a while. So actually think about bubble bursting. I would say add anti-racism. Here are two things. Add anti-racism to your scope of work and bubble burst. And those would be, and the third, I guess, share power. So name racism, bubble burst, and share power. I'm writing these things down too. Okay. So I guess that's it, if that's the last one.
yeah. And I think ending on sharing power is a beautiful way to end it. So thank you so much, Dr. Jones. I don't think there are words to capture how amazing this was and how much we appreciate you coming in to do this talk. I think that just on behalf of APT and the people that attended who are not APT employees, just thank you so much for your time, for sharing your experience, just everything, your power. We just really appreciate you. As a reminder to everyone who is still on, we will be sharing the recording, we'll be sharing the slides with everyone who registered, and all APT staff you'll get an email as well with the slides and the recording and the resources. But thank you again. I hope everyone enjoys the rest of your day and participates in the other Black History Month activities. And again, thank you, Dr. Jones.
Thank you all. Thank you, Chloe. Thank you very much.
Thank you.